Questions?
Leave the mic with us. There's a mic to the podium.
Husband.
Yeah, I have a question for Chris Meyer, because you were showing this table from Magabine's review, where you show that there's a significant increased risk of TIM3 plus in both those who are HPV positive, those if they are cytology negative and they are cytology positive. It's significantly increased in both of these groups if they're HPV positive. But how does that fit in with your recommendation of using cytology as a triage method for those who are HPV positive?
Sorry, we use cytology for triage because it increases the specificity, and of course, if you miss then by cytology in the beginning, as if you do it at baseline, you miss then a number of CAN2 and 3 lesions. But if you repeat this within 6 or 12 months, then you pick them all up, and that's the method which we use for triage. We don't do triage by cytology just on baseline, but also on 6 months. And if you look then to the risk, then you clearly see that the risk is very low. There's one important point which I should say, and this is important. If we talk about HPV testing and the negative predictive value, then if you are screen negative at the beginning, you have a very low risk and you can extend it. But if you are HPV positive and you are triaged 2 times negative, then you need a follow-up within 5 years. So for those women, you cannot extend the screening program because then they come over the threshold, which is accepted in the Netherlands, 2%, but in fact it is 1.2% or something like that.
If you're going to do triage of HPV positive women with cytology, make sure you get a brush up into the endocervix, because the things that you want to know about in that group, some of the most important ones are going to be in the endocervix.
There was a
So, here, George. Sean Boyle from Roche. That's a good transition to my question, because I noticed that in your talk you made a couple of adjustments to the colposcopic procedure to try and catch more disease. In one case, you doubled the number of biopsies, and then later on you said you directed endocervical curettage for a certain subset. So my question is, do you have evidence or recommendation for, or are there even better tools for detecting adenocarcinoma, knowing that it's hard to find them usually deep in the cervical office?
Was that to me?
You are? For you?
Well, we're outliers in this regard. In 2008, we told our docs that we wanted them to start taking 4-quadrant biopsies with the small punches in the fashion of Pretorius and Bellinson, and we've been doing endocervical curetages uniformly with every colposcopy since the late 1990s.
I would make a comment. Maybe. Well, after.
If I have a liquid-based pap smear negative, but HPV positive, the ECC is its endocervicitis. When you recommend the next pap smear then in the U.S.-based medicine?
1 year.
In 1 year?
No, if I can make there is a point which is, I think, is relevant about regression and overdiagnosis. I think the first point to have clear is that cytology causes overdiagnosis. It is very clear from the data, from the New Zealand data, that 1/3 of CM3 becomes a cancer in 30 years, which means that you overdiagnose 2/3 of the relevant vision. This must be very clear. So there is space also to reduce overdiagnosis with cytology. The second point is that with HPV, the point is not to, when we are speaking of overdiagnosis, that we are saying that there is no more overdiagnosis than with cytology. About this, when Chris spoke about CN2, I think that to consider overdiagnosis, we should consider all the lesions together, because of course, if you find the CN2, you can treat it and prevent the CN3. If you find the CN3, you treat it and prevent the cancer. So to have the idea of all the of overdiagnosis, it's globally, it's the sum of everything. And if you take the sum of everything, probably the overdiagnosis in povascum is extremely small. So this is a point. But the other point, and I must say that the design of povascum in which you had the HPV test in the second round for everybody is ideal to define overdiagnosis, because if a lesion was missed at the first round by cytology but detected by HPV, it should be detected by HPV at the second round, so any difference is due to regression. Instead, in the studies like NTCC or the others, we did see large difference in the first two rounds, but this is overdiagnosis is not the only explanation. The other obvious explanation is that the lesion is not really yet detectable at the second round by cytologists, which means that you have longer gaining lead time. Nevertheless, I must say, when I heard speaking about people age 25, that the data from povascum are substantially from women from 30. And in younger women, in our study, the difference in the cumulative incidence was so enormous that it suggested that there is relevant overdiagnosis below 30. And this must be taken in account when before starting at VSA.
We have another question over here.
My name is Jean Damour. I'm from Rwanda. Thank you all for your powerful presentation. I have some questions regarding the rest presenter. So I liked the way you were arguing about why we should prefer biomarkers comparing to other screening tests that are being used. I would like you to make some comments on the cost effectiveness of those tests, because like some developing countries, they are preferring other methods because of some financial limitation. And the other question is, if I would like to know how far are you in promoting those biomarkers so that they can be used. Another question is, if some genes have been identified, those are responsible for causing cervical cancer. Can you make some comment on gene therapy if the science has gone that far? So the last question is,
You remembering this one?
the last question is, if we talk about the test, we talk about the sensitivity and the specificity. So when you study those specificity and the sensitivity for the biomarker, what's the gold standard test we use?
Can I ask you one thing right now? The next session right after this is on screening and countries that are challenged by less resources. So some of these questions will actually, at least the cost effectiveness of some of the ways of approaching screening in areas that aren't like the U.S. or Europe will be, I think, will come forth in that. So I think that maybe some of that could wait. But
Let me just quickly address one thing. I hope that my talk did not come across that I thought that the biomarkers were going to replace HPV for screening. I don't think any of the biomarkers are going to have a sensitivity as high as what we see with HPV. And I think everybody in this field currently believes, with current data, that the primary screening test will be HPV. The challenge is, how do you triage HPV positive? A lot of different options. We've got genotyping, which takes you part of the way there. We've got cytology, which takes you part of the way there. But we know with Dr. Kinney's data, there are 44 invasive cervical cancers in the Kaiser system who were high-risk HPV positive, cytology negative. So I personally think we do want additional biomarkers. Dr. Kinney?
That was just through 2009. We're up over 100 at this point.
In terms of cost, I think most of these are going to be relatively expensive and certainly do not fit into developing country scenario. The one which may be cheap enough to do that would be immunostaining with P16, because that's simply antibody immunostaining. Again, though, there need to be more studies on that in the adjunct arms of screening trials. CARE HPV was just approved by the Chinese FDA, I think yesterday or the day before, a couple of days ago. So that's now becoming available, so we will have HPV. And finally, as far as gene therapy, there are no gene therapies currently available for this. Studies looking at immunizations are being studied, and data is somewhat borderline on that as far as therapeutic vaccines.
I have one question, and I think I know your answer to it, but considering that about 86% of adenocarcinomas are caused by 16-18, do you see, Kaiser's moved towards co-testing faster than anybody else. Do you see a point where if primary screening in the U.S. were approved with HPV testing, that Kaiser might take that initiative and use 16-18 as at least part of the triage? Since adenocarcinoma is what you're most concerned about, or finding adenocarcinoma type 2?
That sounds like a question for me. I don't believe that we will do primary screening in the Kaiser system anytime soon, and the reason is that we are not willing to give up the very small increment in sensitivity that the cytology provides. There are absolutely PAP positive HPV test negative cancers in our experience. Of the 87 cancers that were reported by Dr. Schiffman and Kotke in that first Lancet Oncology report in 2007, 10 of them were HPV test negative at outset. So no, I think we're going to keep doing co-testing for now. It's perfectly plausible that the HPV testing will get better over time, because clearly the cancers are HPV positive. We're just not detecting them at the level of sensitivity that we would like.
In what same token, you will not increase to 5 years at the Kaiser?
We've elected not to increase to 5 years at this point for the modeling reasons that I showed you. When we have data that says that we can provide protection equivalent to annual cytology with 5-year testing, we'll absolutely do it.